Hello and welcome to the first video on female reproductive pathology. In this video I'm going to review the assessment and treatment of female disorders with a focus on more endocrine disorders, and then in subsequent videos we'll look at some specific examples of female endocrine disorders. I won't be covering gynecologic topics here. This is going to be for the naturopaths listening. This will be covered in gynecology. If you're in Chinese medicine and listening to this video, I'll be covering this in a separate series of videos. So I just want to say a few words about the gynecologic exam. There's a bit of controversy going on right now about the need for the frequency of these exams and so forth, and I'm not going to get into that here. But I just want to review some of the major aspects of the gynecologic exam, and that would include the pelvic exam, the breast exam, and then various labs. And I want to go in detail and look at the different types of labs that are used. So starting with the pelvic exam, this includes, examination of the external genitalia, the speculum exam with the pap smear, the bimanual exam, which is used to sort of palpate the uterus and the ovaries, looking for any other lower abdominal masses, and then the rectovaginal exam. So that's all part of the pelvic exam. Stanford 25, which is a series of physical exam videos, which is available online, is a really good resource for reviewing this. The pelvic exam really just involves the external examination again, looking at the external genitalia for any swelling, ulceration, nodules, discharge, lesions. It includes the lower abdominal exam, which would include palpation of the inguinal region, inspection of the mons pubis, the labia majora, and the perineum, and then inspection of the labia minora in the vestibule, and the urethral meatus and the vaginal introitus. Palpation of the Bartholin's glands to make sure there's no accumulations or blockage of the gland there, or enlargement, and then inspection of the anus. So that's all part of the external exam. The speculum exam involves the pap smear, and this is using the speculum after insertion. We're checking for lesions, color, friability, discharge on the cervix. So we want to look at the vaginal wall, but we're focusing mostly on the cervix with the speculum exam, and then obtaining an endocervical specimen using a cytobrush. And then the bimanual pelvic exam is with lubricant, which is applied to the middle and index fingers of a gloved hand. The fingers are inserted into the vagina, and then the cervical cervix and the os are palpated, and then we check for any what's called cervical motion tenderness. So if you move the cervix, if it's very painful, that's sometimes an indicator of a STI, sexually transmitted disease, or any sort of cervicitis, inflammation of the cervix. We palpate the uterine body, noting the size and the position, and then we attempt to palpate the ovaries as well, checking for any masses. And the final part of the pelvic exam is the rectovaginal exam, to look for a retroflex uterus and any adnexal masses. And we also use this to detect the presence of hemorrhoids, any polyps or growths, and assess the anal sphincter tone. So that's all part of the pelvic exam. The breast exam is the next part of the gynecologic exam, and that's inspection and palpation of the breast, looking for size, symmetry, contour, retractions, any dimpling, skin color and texture, looking for any lesions, and then inspecting the nipple for its size, shape, symmetry, inversion, any discharge, and so forth. And then finally, standard labs that are often done in conjunction with the gynecologic exam would be urinalysis, and then possibly with culture if there's any indications of infection. A possible vaginal wet prep if there's a lot of discharge or we suspect vaginitis of any sort. And then specific endocrine testing, which I'll discuss in the next slide here. Now, in early life, in pre-teenage and teenage years, one of the things we're on the lookout for is any signs of hypogonadism. So this would actually be hypoestrogenism. Sorry about that. So hypoestrogenism. So any lack of development of secondary sex characteristics or any other signs or symptoms of low estrogen. And one of the ways we do that is using what's called the Tanner scale. There's a Tanner scale for boys and for girls, and we rank the Tanner stages 1 through 5. And this has to do with the scale of physical development. So it's measuring primary and secondary sex characteristics. Specifically in females, looking at breast size and pubic hair development. So a Tanner scale 1 would be no breast development, no pubic hair. Tanner scale 5 would be full breast development, pubic hair. So that's a fairly subjective scale, but it can be helpful for assessing the degree, if any, of hypoestrogenism. All right, so that's a little bit about the gynecologic physical exam. Now, for assessment of the female reproductive system, we use several basic hormone tests, and the need for these will, of course, depend on our underlying clinical suspicion for different disorders. But with estrogens, we of course have 3 estrogens: E1, E2, E3, and they can be measured either total or free. Remember, E2 is the primary premenopausal estrogen, and E1 is the primary postmenopausal estrogen. Most commonly, especially premenopausally, we're just measuring E2, 17-beta estradiol. Some non-standard tests now measure estrogen metabolites in the urine, for example, and that's the Dutch testing. This is not a standardized endocrine test, but it's being promoted in the functional medicine circles, especially with naturopaths, is a way of getting a more nuanced picture of not just all the different estrogens, but all their metabolites together with all the other sex hormones. So it's a very involved test. Whether or not that level of testing is needed in most cases is a question, but certainly that's out there. We typically use, for measuring estrogen in the conventional sense, plasma tests, blood tests, or we can use a 24-hour urine test or saliva. Now, importantly, this is something we need to tell our patients, that biotin and biotin supplements can interfere with plasma estrogen tests. So we need to stop for at least 72 hours before the test. And why would we measure estradiol? Well, we would measure that, for example, if we suspected any hypogonadism or developmental disorders in children or delayed puberty, to assess reproductive function and assisted reproduction in premenopausal women, so for infertility, testing for any feminizing disorders in males, like if a male has gynecomastia, and we measure E2 if we suspect any estrogen secreting tumors. We typically don't measure estradiol levels if we in menopause, and I'll get back to that later. But sometimes there's a need for it in evaluating, or often there's a need for it in evaluating premature ovarian failure. So we'll go over that. Sometimes we need to measure both estradiol and estrone, E1, and that would be for the following reasons. So any inborn errors of sex steroid metabolism, any disorders of puberty, again, estrogen deficiency, in this case in men, determination of fracture risk in menopausal women, because remember, E1 is your primary estrogen after menopause, and then for any therapeutic drug monitoring if a woman's on hormone replacement or anti-androgen therapy. All right, so those are some of the indications for why we would test for E2 and E1 and E2. Again, the standard test is usually a plasma estradiol test, but you can also measure E1 and E3. E3 is very rarely measured because, again, that one is primarily an estrogen in pregnancy, and in premenopausal women that are non-pregnant, it's at fairly low levels. Less commonly, we'll measure the free estrogens, but typically we start with a total. And the ranges are going to vary, of course, depending on if you're in the follicular phase, if it's being measured during ovulation, or during the luteal phase in menopause, or in pregnancy or children. So the different, make sure when you order estradiol, plasma total estradiol, that you check the age and the reference ranges that are appropriate for that. It's important to, usually the test just reflex to measure sex hormone binding globulins as well, to give you a sense of how high those are and whether or not that's binding up a lot of freely available estrogen or not. Okay, so that's plasma testing. There's also 24-hour urine testing, which again, like the Dutch testing, can capture the estrogen metabolites, which again, I discussed the estrone metabolites in the previous set of videos. And we think some of those might be pro-carcinogenic, so getting an estimate of those levels can be helpful in some women. And then salivary testing is not a standard test, but this is fairly commonly used. and the ND in functional medicine circles, and this measures the free hormones directly. So those are our three options for measuring estrogen: plasma, urine, and salivary. Progesterone, this can also be done through serum, saliva, or urine. Some sources argue that the best estimate of free progesterone levels is from salivary testing, and there's various reasons. Of course, progesterone is carried by binding globulins in the blood. There's also a percentage, which I didn't mention before, which is carried inside of red cells, so it's dissolved within the red cell membranes, and then that diffuses into the tissues. So that is another pool of progesterone which can contribute to free levels. So ultimately, the proponents of salivary testing argue you got to measure the downstream progesterone, and the best way to do that is through salivary testing. Here we might use progesterone testing if we suspect any ovulation defects or decreased corpus luteum function, like an anovulation or lack of corpus luteum. Monitoring patients with HCG-induced ovulation, again in fertility treatments, and then evaluating patients at risk for early abortion. These would all be indications for progesterone testing. Other hormones that can be considered in workup, we'll go through these with individual examples, but of course, one of the things we always want to check is maybe getting a pregnancy test, especially if a woman presents with amenorrhea. That would be the first thing to do. LH and FSH have their roles. Typically we measure those in the morning, 8 to 11 a.m., and we want to get 2 or 3 samples that are 20 to 40 minutes apart. So that's the typical measurement, or how it should be measured, but that's not always what labs do. Sometimes they'll just do a single draw, and I sometimes have to send patients back to make sure we're getting accurate measurements. Prolactin, this is going to be elevated a little bit after eating, so we got to abstain from eating at least 3 hours before a sample's taken. And then testosterone, get total or free. DHEA has a role, for example, in PCOS. We'll come back to that. And then if we suspect in a woman, for example, that has a lot of androgenic or has a lot of virilizing signs, we might suspect a congenital adrenal hyperplasia, and that's where we can measure the levels of 17-hydroxyprogesterone, which will be elevated in CAH. So that's going to be usually something we measure in early life or puberty. Okay, so that's some of the hormones. Imaging that's used for gynecologic conditions, of course, ultrasound, there's pelvic and transvaginal, CT and MRI, and then laparoscopic procedures can be used as well. So we'll be seeing examples of all these as we go. So I just want to say a few words about the general approach to treatment of female reproductive disorders, and then I'll give specific examples with each condition that we go through. But typically we want to, of course, use the therapeutic order, and a lot of functional conditions, menstrual disorders, even menopause, and some types of secondary amenorrhea, really will only require level 1, level 2 treatment, and that would be our dietary measures, making sure we have an adequate diet, but also looking potentially at anti-inflammatory diets. In low estrogen states, we might think about soy and flax as possible additions to the diet. Getting adequate exercise. Again, a minimum standard there is about 30 minutes, 4 times a week, of a mixture of aerobic and anaerobic. So that's going to be kind of the minimum standard there. And then lifestyle adjustments, making sure a woman gets adequate sleep for melatonin, emphasizing smoking cessation, alcohol reduction. Usually the current guidelines suggest that 1 glass of beer or wine a night for a woman is the kind of maximum limit for alcohol. For some reason, and that's probably because of differences in metabolism, the guidelines suggest 2 glasses of wine or beer for a male is the upper limit. So that's the current guideline out there, but more and more evidence is actually showing that even any degree of alcohol, we thought alcohol had a protective effect, for example, against different cancers and so forth, and now we think it's probably not the case, and so alcohol has a pretty low threshold in terms of what the maximum amount should be. So that's something we just have to discuss with our patients. I think we have to look at the fact that different types of alcohol, wine or whatnot, might actually have an anxiolytic effect for a lot of people, and that has more benefits than maybe the negative effects of the alcohol. So it all has to be weighed. And then stress reduction and counseling therapy. So that'll all be level 1 treatments. Level 2 is, I think, where a lot of naturopaths, Chinese medicine practitioners will focus their efforts, and that's really working again with the neuroendocrine terrain in Chinese medicine, doing pattern differentiation. But typical herbal classes that are used in female reproductive disorders would include the phytoestrogens, and I'll go over those shortly. Phytoprogestins, which have progesterone sustaining effects in the body, phytoandrogens, which we went over already in the male reproductive section, stimulant adaptogens, which would work with DHEA, and then nervine herbs might be indicated, liver support for improving clearance of estrogen and estrogen metabolites. So those would all be some examples of some of the approaches. And again, we'll go into specific treatments as we get into different conditions. Level 3 would be replacement therapy. And with replacement of hormones in females, this could involve replacement of the estrogen, usually 17-beta estradiol, but we see a lot of compounded estrogen now, and I'll get into that. And this would be compounding, for example, E2 with E3 through a compounding pharmacist, and taking this as a capsules. But typically, again, like with testosterone, there's if you take these hormones orally, there's a large effect from liver metabolism. We tend to have more adverse effects from oral consumption. So we try to emphasize more transdermal forms. Progesterone, same thing, that might be replaced, and we have to be careful if a woman has a uterus, if she's on estrogen replacement therapy, she's going to need to take a progestin, and usually progesterone is the one that's most commonly given now. She has to take that with the estrogen, because estrogen causes proliferation of the endometrium, and unopposed proliferation, if there's no progesterone, could result in increased risk for endometrial cancer. So I'll go over the risks and the benefits as we go here. But for premenopausal females, typically estrogen is used for premature ovarian failure, and it's usually given up until when natural menopause would have occurred, around 50 to 51. And there's different dosing regimens. So we give, for example, continuous transdermal estradiol, 100 micrograms a day, or there's a vaginal ring, for example, 100 micrograms a day. There's many, many forms of estrogen. I can't go through them all here, but these would be some very commonly prescribed estrogens. And then for the first 12 days of the month, we give micronized progesterone, which is becoming the more popular form. This is the natural progesterone and a special micronized form, and we give this orally, 200 milligrams a day. There's also a transdermal progesterone. I'll come back to that. That might not be as effective as the micronized for getting progesterone levels up. Or medroxyprogesterone acetate, which is the synthetic progestin, is given 5 to 10 milligrams for 12 days. So these would be some of the progestins given alongside the estrogen. Oral contraceptives are also sometimes given, but they're not going to be adequate for ovarian failures we'll go through. So that would be premenopausal hormone replacement. Postmenopausal, I'll talk about that. There's a whole different regimen with that, and usually it's using lower doses of estrogens, not so much mimicking the physiologic dose, but trying to get sub-physiologic doses. All right, so that's level 3 therapies, replacement. Level 4 is going to be vary by condition, but common medications that might be given would be antiestrogens for some conditions, selective estrogen receptor modulators, SERMs, bisphosphonates for osteoporosis, osteopenia due to low estrogen, SSRIs, SNRIs are commonly given like for menopausal hot flashes or in PMS, things like that. And then there are different surgical techniques, either diagnostic or therapeutic. So that's just a generic summary of all the different kinds of modalities that are commonly used in the treatment of female reproductive conditions. So there's a lot of controversy about female hormone replacement therapy or hormone replacement therapy, HRT. So I want to kind of get into that and talk about some of the important things we need to know here. So there's different forms of HRT. There's estrogen only replacement, that would be ERT. And again, that would be through bioidentical E2, maybe E3 and that could be compounded, or there's pharmaceutical preparations. I'll review those here in just a minute. And then there's animal-derived estrogens, and the most common one there would be conjugated equine estrogens, CEE. These come from pregnant mares, and this contains some human estrogens, but also some horse estrogen metabolites that are unique to horses and not to humans. So there's a bit of controversy, and we're seeing more and more people are using these less and less, and using the bioidentical hormones, even in the conventional circles. And then there are synthetic estrogens like ethinyl estradiol. You see that added to oral contraceptives commonly. Okay, so that would be estrogen-only replacement therapy. Then we have the combined estrogen-progesterone therapy, EPT. And again, that's required for women with an intact uterus. Unopposed estrogen can cause endometrial hyperplasia. That increases the risk of endometrial cancer. And that risk can occur as early as 6 months of unopposed estradiol use. So we don't want to just give estradiol without a progestin if a woman still has her uterus. Common progestins that are used are the bioidentical ones, and that would be oral micronized progesterone. The micronized has more of a slow release, so it's not just, it retains more in the body over time. There's also transdermal progesterone. The synthetic form of progestin that's commonly used is medroxyprogesterone acetate, or MPA. And then there are other synthetic progestins like norethindrone or esterone that are found in oral contraceptives. The progesterone is, we went over all the effects of progesterone in the previous video, so you might want to go review that. Remember, with breast development, that both growth hormone and estradiol are important for breast development in early life. Progesterone, though, has more of an influence month to month with cyclic changes in the breast, so it acts as an anabolic hormone there. Okay, so that's combined treatment. More controversial is androgen replacement in females. This is becoming a little bit more popular. There's only one approved use of androgens by the FDA, just so you know, and that is for what they call female sexual dysfunction, low libido, and so forth. There's some people are using testosterone replacement alongside the estrogen progesterone replacement, because we do know that androgens have a role in females, and postmenopausally, low androgens could contribute to fatigue and low muscle mass, etc. So there's no real guidelines, and I'll refer you back to the previous notes we had on testosterone. That's very similar for in females. I think commonly I'm seeing not so much the gels used for androgen replacement, but the testosterone pellets that are placed in females. And this leaches testosterone over usually 6 months, and they need to be replaced. DHEA would be another androgen. There are no clear guidelines. Typically, though, we want to use levels a little bit lower than in males. And so some authors suggest 5 to 10 milligrams a day is kind of what you want to aim for with DHEA if you're going to be supplementing it. There's many forms of these different hormones. There's oral, capsules, tablets. Again, they're going to have the most adverse effects because of first-pass liver metabolism. There's transdermal, patches, gels, creams, vaginal forms, creams, suppositories, rings, tablets. There's intramuscular and subcutaneous forms, subcutaneous implants, as I just mentioned. Less common, we have sublingual or buccal or intranasal or rectal forms. And then there are intrauterine devices. So lots of forms. It gets very confusing, but I'm going to try to stick with what's most commonly used in terms of which preparations for the different conditions we'll be talking about. What are the indications for HRT? Well, in females, with one indication would be contraception, and that's with either progestin or progesterone only. And the way that's working is essentially to shut off the gonadotropins from the pituitary, and so it's interfering with the ovulation cycle and so forth. In menopause, this is part of what's called menopausal hormone therapy. That would be an indication for HRT, and I'll talk about the risks and the benefits of that as we go. And then premature ovarian failure, which we'll talk about in more detail, but basically that's failure of the ovaries before the age of 40. so no estrogen is secreted, and that can lead to significant problems with osteoporosis and increased cardiovascular risk together with all the vasomotor symptoms like hot flashes. It's used in transgender women as part of feminizing hormone therapy. And then in males, HRT, high-dose estrogens might be used in some cases of prostate cancer treatment. I just put that there for completion. I don't see that commonly used. It does act as an anti-androgen. And by giving, remember, estrogen is one of the potent stimulators for the liver to release more sex hormone binding globulin, and that will bind up more androgens. And the idea is that will prevent the dihydrotestosterone and the androgens from increasing prostate growth and prostate cancer. This has been usually replaced now with anti-androgens, but I put it on the list because it has historically been used for that. I'll talk about the risks of HRT on the next page here. Here in the right-hand column are just some examples of, in more detail, of some of the estrogens. So we have our bioidentical generic, so that's 17-beta estradiol. Usually, again, in menopause, we're going to use it in lower doses. In premature ovarian insufficiency or failure, we're going to use it in higher doses, more physiologic doses. Common forms, again, would be oral, but again, transdermal is probably the most popular here, 25 to 100 micrograms a day. There's also vaginal forms between 50 and 400 micrograms a day. The compounded estrogens are promoted often. These are the so-called bioidentical estrogens, although again the generic 17-beta estradiol is bioidentical. But the compounded estrogens are often promoted as having less adverse effects as the more synthetic or semi-synthetic forms of estrogen. But these are not FDA approved, and a lot of people don't know that. The FDA argues that these are no better than the synthetic or semi-synthetics in terms of the adverse effects of estrogens, which I'll talk about coming up here. But they are very commonly used. Probably the most common combination is biest. There is a triest as well, which combines all three estrogens, but biest or biestrogen. And again, this is prepared through a compounding pharmacy. So your typical pharmacy at Walgreens or Fred Meyer will not be able to prepare these. You have to go to a compounding pharmacy. In the Portland area, a common one is Lloyd Pharmacy that we use for this. This is the usually either in capsules or sublingual. There's also a transdermal gel or cream. I like the transdermal just because it has less of the liver, first pass effects. And that's typically 2.5 milligrams transdermal per day. Note that E3 has a potency of about 1/80th of E2, so this is why critics say, well, it doesn't really do anything, but we think that E3 again has more of stimulation of the beta receptors, so it's kind of helping to balance, and it's having a little bit of an antagonistic effect at the alpha receptors. So it's preventing overstimulation of those receptors. That's the argument for this. This is hypothetical and conjectural, but that's why people often combine these two together. The animal-derived estrogens I mentioned, the conjugated equine estrogens, these are being used in less and less, but this is Premarin, and the typical dose of that is 0.625 milligrams a day orally. Prempro is the Premarin plus the medroxyprogesterone acetate, 2.5 milligrams a day. So Prempro combines the two. And I'll talk about the big study that raised the big red flag with Prempro several years ago coming up. But after that study, this was the Women's Health Initiative study. After that study, the use of these hormones dramatically dropped off because we hear all these negative effects from that study. For example, that it increased breast cancer and so forth, and blood clots a lot more than we thought. But I'll come back to that because that argument's going to be nuanced depending on the age group and whatnot that you're talking about. Progesterone, again, a micronized progesterone or MP, we have oral 200 milligrams a day, either 12 days a month or 100 milligrams a day continuously. So there's a difference between what we call cyclic and continuous dosing. Cyclic would be trying to mimic a menstrual cycle. And for example, in menopause, we try to do that for a couple of years. If we start HRT after menopause, we try to do that for a couple of years after the cessation of menses to try to mimic a normal reproductive cycle. But if it's been a few years, then we just go to continuous dosing of the 100 milligrams a day with the estrogen. Transdermal is usually 20 milligrams a day. There's concerns that transdermal progesterone doesn't really reach the levels we need to prevent endometrial hyperplasia. And so different sources are saying different things, and it's really a kind of a controversial area. So we tend to stick with the oral because that's what's been kind of historically used. The synthetic progesterone is again medroxyprogesterone acetate, or MPA, 2.5 milligrams oral. We think with this one, there is pretty good evidence that there's increased risk for more coronary heart disease as well as breast cancer. So more and more people are switching to the micronized progesterone. Testosterone is again not recommended by most guideline committees for routine replacement, but it is being used, and I talked a little bit about the different strategies there. And then DHEA, no guideline committee recommends this, but again, if it's going to be used, we use very low doses, typically 5 to 10 milligrams a day. All right, so that's a little bit about the hormone replacement in general. Now, one area where we see the hormone replacement therapy used is in menopause, and I'll talk about menopause in depth later in a later video. But I want to say a little bit about just using HRT in menopause here. So the benefits would be to reduce vasomotor symptoms, hot flashes and whatnot, to reduce vulvovaginal atrophy. And typically, I'll talk about that here. If there is vulvovaginal atrophy, now that's referred to as part of what's called now it's referred to as the genital urinary syndrome of menopause, GSM. And if a woman presents in menopause with that as her primary concern, then we typically just recommend topical HRT. And interestingly, with topical HRT, like estradiol topically in the vagina, there's no need, if it's low dose, to use a progestin or progesterone. So that's one instance where we don't need the progesterone. We see benefits with HRT with decreasing osteoporosis, and we think maybe a low-dose HRT could be beneficial there. Now, with the invention of the bisphosphonates on the market, a lot of doctors are just recommending those and not recommending hormone replacement therapy, but there is a role, and I'll say a little bit more about that here in a second. Another very important benefit of HRT in menopause is mood support. So remember, estrogen supports serotonin. And we see with the drop of estrogen after menopause, especially estradiol, that the serotonin levels go down, and this could trigger depression. And I've seen very severe depression develop shortly after menopause for some women. So this would be an indication for HRT there. And then we think it could give cardiovascular protection. It's complicated because too much estrogen increases blood clots, but you do need estrogen to protect endothelium. We know that the physiologic levels of estrogen will decrease LDL and increase HDL and decrease triglycerides, hopefully. So these are all potentially cardiovascular protective effects from the therapy. Now the goal, I'll talk about the risk here in a second, but the goal would be with menopause, to, number one, use on the therapeutic order level 1 and level 2 therapies first, and I'll talk about those later. But if we are going to use HRT for whatever reason, we usually try to use them as little as possible, so under 5 years, or until the age of 60. So most of the studies are showing that if you give HRT under the age of 60, the benefits far outweigh the risks. But after 60, we start to see that the risks outweigh the benefits of HRT. So that's something to keep in mind. So some common regimens with estrogen for menopause would be, again, transdermal, estradiol, 20 to 50 micrograms a day, the Premarin, 0.625 milligrams a day, the bioidentical hormone replacements, that would be the transdermal Biest. So it'd be 20% estradiol, 80% estriol, for a total of 2.5 milligrams a day. If you ever have questions about this, if you think it might be appropriate to use this therapy in a patient, you can just call the compounding pharmacy and they can walk you through how to put together a prescription for that. So they're always very helpful in that regard. In terms of for the genital urinary syndrome of menopause, vaginal low dose, that's 25 micrograms, 1 to 2 times a week is typically what's used there. Now, a couple of notes. The FDA does not endorse the bioidentical hormone replacement therapy due to lack of evidence. And the treatment, again, of the GSM can be with the topical vaginal estradiol with no need for progesterone therapy. And we find that transdermal estradiol is just as effective as oral estradiol for preserving bone density. So if you're just using it for osteoporosis prevention, etc., then we can use a transdermal form. The typical progesterone forms, again, could be given continuous or cyclic. We try to give the cyclic use in early menopause, and then continuous 2 to 3 years post-menopause. And that would be primarily the oral micronized progesterone. And that would be, again, cyclic 200 milligrams a day times 12 days beginning at the month, and then continuous would be 100 milligrams a day. There is a transdermal micronized progesterone, which is typically 20 milligrams a day. It's not as commonly used for menopause, and we, again, have a question mark as to whether or not the doses prevent endometrial hyperplasia. And then there's the oral medroxyprogesterone acetate, the Provera, and that's usually given continuously at 2.5 milligrams a day. But some evidence might suggest a cyclic would be better there. But again, most doctors are starting to move towards the oral micronized progesterone. And then androgens, testosterone would be typically 0.5 to 2 milligrams transdermal a day, and then DHEA, again, 5 to 10 milligrams a day. And that's more to improve libido and sexual dysfunction. We have no data on whether or not these improve bone density, mood, cognition, or any of the vasomotor symptoms yet. Okay, so that is the different hormones used in menopause. Now, what are the adverse effects, which are important here? So the big problems are that too much estrogen can increase blood clots. So venous thromboembolism can lead to ischemic stroke, increase the incidence of coronary artery disease, especially blood clots forming on top of an pre-existing atheroma, increase gallstone risk, and cholecystitis, especially with the oral forms of estrogen. And then the big one here is increasing cancer risk, especially endometrial, ovarian, but breast is probably the biggest one that's talked about. And that is after 5 years or more of use continuously. So these are the reasons why we don't want to use estrogens, and we have to be very careful about that. So I'm, again, trying to really focus on level 1, level 2 of therapeutic order before jumping to replacement therapy. And if I'm going to give replacement, I'm going to make sure that a woman's ability to detox these things is adequate. So there's proper methylation and sulfation and all these pathways in the liver going on. The risk is decrease of these adverse effects with the transdermal estrogens, so there's no first pass metabolism, or the low-dose oral estrogens, or starting HRT within 10 years of menopause, and starting HRT under 60. So that's going to minimize our risk of these adverse effects. The risk is, again, increased with oral estrogens, and by going through first pass metabolism, it just causes the liver to super secrete these clotting factors. It's going to increase triglycerides and CRP, and that will push down LDL, but you have all these, more of a pro-inflammatory state. It's going to increase more cholesterol in the bile, contributing to gallstones. It's going to raise sex hormone binding globulin more if you take it orally, and that's going to decrease free testosterone levels. It's going to increase thyroid binding globulin, which would decrease available thyroid hormone, creating more of almost a subclinical hypothyroid picture. And it's going to increase corticosteroid binding globulin, and that could increase the total amount of cortisol, but that can less of the free cortisol available. So this would all be problems of the oral estrogens. Other things that would make the risk factors more or worse in a woman taking estrogens would be tobacco smoking, alcohol, having an ASCVD risk over 10%, and the use after the age of 60 or more than 5 years into menopause. So this is some things we can look out for and try to minimize the risk a little bit more. Contraindications for ERT in menopause would be unexplained vaginal bleeding, history of stroke, TIA, MI, PE, venous thromboembolism, breast or endometrial cancer, active liver disease, clotting protein disorders like protein C, S, antithrombin, pregnancy, and then use caution with gallbladder disease, diabetes, increased triglycerides, and migraines. It could precipitate migraines for some women. All right, so those would be contraindications for ERT, not just for menopause, I should say, but for any woman. Some considerations would be to calculate the ASCVD risk in a woman before prescribing. If her risk is more than 10%, her 10-year ASCVD risk, then we should not really consider estrogen replacement therapy. We need to get regular mammograms and then monitor for any vaginal bleeding, breast changes, or cardiovascular disease. All right, so that is, in a nutshell, what we need to think about with hormone replacement therapy. And this example I just gave was around menopause. I'll come back to menopause and talk about, again, the studies that we were really concerned about. We'll talk about that later, but this hopefully gives you a little overview of the different types of hormones that are used and the dosage regimens and what are some of the adverse effects we need to be considering. I just put this chart here. This was taken from Up to Date. It's probably a little different. This was from 2015. It might be a little more updated since then. But it just gives you an example of all the different estrogen and progestin products out there on the market. So it's a very complex market. But again, the forms that I indicated previously are the ones that are most commonly used. Now, just like we have a class of herbs that can augment androgen activity in the body, we have a class that can augment estrogen activity, and these are the phytoestrogens. Again, some people are thinking about maybe renaming this category the phytoserms, selective estrogen receptor modulators, because in reality, the phytoestrogens kind of work like adaptogens to the estrogenic system. So if you have low estrogen, they tend to increase that activity. If you have high estrogen, some of these phytoestrogens can block the effects of estrogen at the receptors, especially the alpha receptor. So remember, we have the two estrogen receptors, alpha and beta. The beta we associate more with some of the beneficial effects of estrogen on bone, on the blood vessel system, on the brain, and so forth. The alphas are more on the reproductive organs, and that's the one, if you overstimulate, might increase the risk of different reproductive cancers. We know that the compounds in phytoestrogens, the isoflavones, or the lignans, coumestans, and prenylflavonoids. These are the four biggest groups of phytoestrogenic compounds. For example, genistein and daidzein are classic isoflavones that are in soy. These compounds preferentially bind to the beta receptors and might weakly block the alpha receptors, preventing overstimulation of estrogen there. So they would have a protective effect in high estrogen states. So these are not just to raise estrogen, they're really to balance the estrogenic activity in the body. Generally, we think about using them, though, for the kind of clinical pattern of low estrogen, and that would be more the kind of menopausal pattern, so dry tissues, hot flashes, vaginal atrophy, that sort of thing. And in Chinese medicine, that dryness is an indicator of what they call a yin deficiency. So this would be a yin deficient state. In fact, we can make an argument that what is referred to as yin in Chinese medicine has a very strong association with estrogen and estrogen activity. In fact, all of the herbs used in Chinese medicine to treat yin deficiency states are phytoestrogens. And so there's a distinct crossover there. Some of the herbs in this category would include Chinese Rehmannia, the dongui, Dioscorea, wild yam, medicago, red clover, hops, shatavari, privet fruit. Now, black cohosh I put in this category, although interestingly, it does not contain any of these constituents in the right-hand column. So we don't, although we consider black cohosh a phytoestrogen, it's given a lot for menopause, the studies haven't been actually that great on it. And I find it's better used as a sedative adaptogen, actually, to downregulate the HPA axis. And I find a lot of women that have sort of been living on cortisol for years before menopause, the estrogen is actually protecting them from the effects of cortisol. But when the estrogen, declines at menopause, now we get the unmitigated effects of cortisol, and that contributes to a lot of the symptoms that some women might experience. So black cohosh could address that. The false unicorn roots, kudzu, partridge berry, Solomon seal, lily bulb, eucalypta, black sesame seeds. I put the Chinese pinyin names after that in case you are interested. Ophiopogon, asparagus tuber, which is, again, shatavari is a type of asparagus. This is the one that's used in Chinese medicine, the tianmendong. And then glenia roots and royal jelly. So these all are examples of phytoestrogens. Minerals that tend to, and metals that tend to upregulate the estrogen process, very importantly, copper. So think of copper as increasing estrogen. Zinc's going to have more of an effect on progesterone, and then iron more on testosterone and androgens. But copper can upregulate the estrogen processes, which is why some women, they get, for example, they might get a copper IUD, and they actually feel better from it. That could be that they had a low estrogen state to start with. If they feel worse, they usually had more of a higher estrogen state. And what I sometimes do there is actually supplement zinc before we remove the IUD to see if that mitigates the symptoms. And a lot of times it does. So that's copper. Silver, I put in here more that, there's not a lot of evidence with silver and estrogen. Historically, silver is used to clear heat and to moisturize tissues. So this was what they called a lunar metal, like the moon. The moon forces were thought to be watery, yin-like, and silver brings that activity into the body. So there might be some crossover here with the estrogenic system. Okay, so these would be some of the classic herbs, and what they're really doing is stimulating the estrogen activity. And just like we saw with the phytoandrogens, they work through different mechanisms. It's still an area that's being researched, but in general, they either increase the synthesis and release of estrogen and the availability of free estrogen in the tissues, or they improve the binding, especially to the beta receptor of the estrogens, maybe antagonize the alpha receptor a little so we don't get overstimulated, and so forth. And so they have a wide variety of action. And all the effects here are really the estrogenic effects in the body, which we've gone through already before. So they treat essentially what we would call a heat atrophy state in the Western kind of language, which in Chinese medicine is yin deficiency, so more of a dryness state. I think of them as very watery, cool, having more of a blue-like signature. And the classic kind of symptoms in Chinese medicine of kidney yin deficiency, again, this would be describing a low estrogen pattern, would be hot flashes, night sweats, vaginal dryness or skin dryness. Remember, the effect of estrogen is increased moisture in the skin, elasticity, scanty dark urine, tenderness, low back weakness, and so forth, and menopause. So that's estrogen. Remember that I mentioned that the androgens are what in Chinese medicine are called yang, and yang deficiency states are low androgen states. So curiously, for menopause in Chinese herbal therapy, we often give either yin tonics that are the phytoestrogens, or combination yin and yang tonics would be phytoestrogens and phytoandrogens. So very similar to giving estrogen maybe with DHEA, that sort of thing. So again, I really try to focus on the level 2 therapies, the herbal therapies, before I jump to any hormone replacement therapy. Some women do need the HRT, I found, but the majority I find we can manage quite well with just the herbal therapies. Okay, so that is a little overview of the category of phytoestrogens. I'm not going to talk here about phytoprogestins. I will mention that later. This is really an emerging class, and there's really not enough data to put together a list. But some common phytoprogestins, like, for example, Vitex, as well as herbs like peony, white peony, would be examples of phytoprogestins. It's curious that there's a very famous Chinese herbal formula called Xiaoyaosan. And this is translated as free and easy wanderer powder. It's used a lot for PMS in states of what we might describe as hyperestrogenism, too much estrogen. And one of the, there's a couple of herbs in there that actually address the liver, like bupleurum, which address liver clearance. But another prominent herb is white peony, which would increase the progesterone levels. So peoniflorin is one of the flavonoids in there, and that we think increases progesterone activity. Okay, so that's a little summary there of phytoestrogens. Finally, I'll mention a little bit here about antiestrogen therapy. This is not as commonly used in primary care settings, but this would block the effects of estrogen. And the indications for this would be any estrogen excess condition in males or females. Again, one way we want to think about excess estrogen, especially functionally, is to just improve estrogen clearance to the liver, and that's one way of dealing with that. But these are used in cancer therapies as part of what's called estrogen deprivation therapy. In males, anti-estrogen therapy might be used in male hypogonadism, so with low testosterone. Any estrogen is going to create a hyperestrogenic state, so we try to block the effects maybe of estrogens, having gynecomastia. In females, typically anti-estrogen therapy is used in estrogen receptor positive breast cancers, in infertility for ovulation induction, and I'll talk about that here in a second, and then postmenopausal osteoporosis. Different SERMs are used for that. And then the therapy is also used potentially in transgender males, part of the masculinizing hormone therapy. So what are the estrogen blockers? Well, estrogen receptor antagonists would include the SERMs, selective estrogen receptor modulators. And these are called SERMs because they have various effects at the alpha and the beta receptor. So some block alpha, stimulate beta, some do the opposite, etc. So one example is clomiphene, which is used, so I'll just mention first, tamoxifen is used in breast cancer, so it blocks the alpha receptor and prevents estrogen from binding in the estrogen receptor breast cancers. But clomiphene is used for ovulation induction, and what it does there is it blocks the alpha receptors in the hypothalamus. And so the estrogen levels, as they increase, normally that should provide a negative feedback to turn down FSH and LH secretion. So when you block the estrogen receptors in the hypothalamus, though, the negative feedback signal is shut off. So the hypothalamus continues to put out GnRH, and you get more FSH actually and LH as well, and that can help follicular growth. Remember, that's FSH is the main hormone which stimulates the growth of the follicle. So if you're trying to induce ovulation and follicular development, clomiphene is a drug that's commonly used for that. Raloxifene is another example here of a SERM. Then we have selective estrogen receptor degradators. Those are called SERDs, and fulvestrant is an example of that. And then estrogen synthesis inhibitors. These are the aromatase inhibitors like anastrozole, Arimidex, letrozole, the Femara. And then there are actual anti-androgens, and these are the GnRH analogs, which I talked about already in the anti-androgen category. So these anti-gonadotropins, would block the gonadotropin secretion, and that would turn down the estrogens, etc. Obviously, the adverse effects of anti-estrogens would vary with the type, but typically it's going to induce a yin deficiency or estrogen deficiency state. So hot flashes, osteoporosis, breast atrophy, vaginal dryness atrophy, reduced libido, and depression. Okay, so that wraps it up for the assessment and treatment modalities used in female reproductive disorders. In the following videos, I'll look at individual female reproductive conditions.